all of you to our event, Public Health, Why It Matters. The Health Care for All Task Group is a working group of the Sisters of St. Joseph Justice Commission, and we are dedicated to the Catholic social teaching principle that access to quality health care is the right of everyone without exception. Today's agenda is we'll have our first speaker, Dr. James Hart. He is a physician, past president of the Minnesota Public Health Association. And our next speaker will be Antonia Apolinario Wilcoxon, who is with Equity Strategies. And then we will follow that with some student presentations. So should we begin with a short prayer?
Great, thank you, Dr. Ellen, and I will start us with a short little prayer. It's a prayer that the Health Care for All group has been using for a while, so I'll just begin. It's, "Oh, holy touch of endless joy, as we begin this day, we come before you in gratitude for the many ways in which you have blessed us, not only with the substance of our meals and our food, but in our ability to gather and pray in solidarity with your most vulnerable ones. With the strength of your loving arm, bless all those who lack access to quality health care, especially the weak, the small, and the voiceless, who need care and healing, medicine and counsel, food and shelter. Call us all out from any and all complacency, that we may be your tender touch of comfort and aid to all who are hurting and all you place before us. Teach us now and always to give our best, to speak with love, to act with courage, and to live with humility. We ask this in God's loving name. Amen. And with that, I'm going to just read a very short introduction to Dr. James Hart, who will be our first speaker this morning. Dr. Hart has worked for 30 years in primary care, medical practice, and management, both independently and with Health Partners, Inc. He also served on the teaching faculty of Regents Hospital from 1994 to 2005. Through 2010, he directed the Executive Program in Public Health Practice and the North Central Public Health Leadership Institute in the School of Public Health at the University of Minnesota. His primary interest is in the intersection of health and society and in restoring democracy and our healthcare system. He served on the Minnesota Healthcare Access Commission in 1989 through 91 and has been a longtime advocate of a unified, publicly funded healthcare system. Dr. Hart has also had a long interest in global health issues. He served on the boards of WellShares International for 13 years and Global Health Ministries for 6 years. In his retirement, he continues to stay engaged in Minnesota health policy discussions and various community health initiatives. And Dr. Hart, we welcome you this morning to begin our conversation about public health, why it matters.
Well, good morning. Thanks for having me. It's a pleasure. I see some friendly faces out there, which is nice. I had the opportunity, as so often happens, to look at the agenda this morning and go, is that what I said I would talk about? These conferences get interesting that way. I was in contact with Jeanette Lucia going back a couple months, I guess, and I think the thing that she was most interested in hearing was why would a physician, a medical physician, become interested in public health and really ultimately have my career end up more in public health than medicine toward the end. So I'm going to spend most of my time on kind of on that topic, which tends to answer the second question if you're looking at the agenda there. The first one I'll dispense with rather quickly. I'm going to pull up slides here in a minute, but on the agenda it asks, what is public health? And The definition that I've always liked the best is the one that actually comes out of the National Institutes of Health, which says public health is what we do collectively. I like that word collectively, to assure that we can all be healthy. So what we do collectively to be sure that we can all be healthy is really what is public health. Now, there's a lot more to it than that, obviously, but that's kind of a nice working definition. Marty, are you going to pull up the slides?
Sorry there, Jim. I did not get the slides. I was assuming you were running your own slides. Can you bring them up on your computer?
Yeah,
and share screen.
I can do that. Let's see here. Give me a second. Yeah, they're not up there now, are they?
They are not on the screen yet.
Okay. I'm in some kind of a rework loop here. There we go. Okay, now, yeah. Let's see. I think I'm getting close.
Yep.
Okay. Up to the top here.
Perfect.
Okay, here we are, October 29th. Everyone's ready for Halloween, I hope. So I'm gonna, this is almost gonna be like the Anglican lessons and carols sort of thing. It's gonna be people I've met along the way and lessons I've learned. I hope this works. I think it will. My path from medicine to public health has been very gradual and incremental. Let me start here. So I was in medical training throughout most of the 1970s, actually. Started medical school in 1971. So by the fall of 1977, I was in actually my final year of residency. Happened to be working at the VA hospital in Minneapolis at the time, and along came this medical student. And when I asked him what he was planning to do, he said, well, I'm going to do an internal medicine residency, which I thought, well, that's great. That's what we all in our department thought was a good idea. But then with further questioning, he said, well, then I'm going to go get a master's in public health degree from Johns Hopkins, actually, and go to work in Africa. And I said, well, you mean like for 6 months or a year? Or, well, no, that's where I'm going to work. And Mark Jacobson, a few of you could know him, especially if you're in the Lutheran circles at all, actually spent his whole career. He just recently retired. So he went to Kenya in 1981 and then to Tanzania, and then literally spent his whole career in Africa. So that kind of opened my mind to the fact that medicine and public health are friends. Now, in medical school, we heard a little bit about this fellow, Dr. Rudolf Virchow, but what we were taught was that Virchow was actually a German pathologist back in the 1800s. And what we learned about Dr. Virchow is he had his name on a particular lymph node, one that lives just up above the left collarbone here. And we were taught that if we discovered a hard lymph node up in that area, we ought to think about the possibility of stomach cancer. What we weren't told was that Virchow was actually also a very robust public health figure. He talks here about protecting the health of the public and physicians as natural attorneys of the poor, if you will. Really some amazing language. So there was more to Virchow than we were taught in medical school. The next person that comes to mind then is a fellow named Håkan Torsen. actually the son of Chinese missionaries to China, I should say. He came out to talk to our medical society back on a cold night in somewhere in the early 1980s about this new organization that they had just put together called Minnesota International Health Volunteers, now known as WellShare International. But this was an organization that came to realize that there were many people, and they were particularly interested in the children over in the refugee camps in Southeast Asia at the time, coming out of the Vietnam War. So they started sending volunteer physicians and nurses over there to help out. I later, as you heard in the intro there, I have been on the board for a number of years. I think I'm actually up to about 16 now. I'm back on the board. But one of the people I met was Alice Nickerson, I mentioned there, who quoted this ancient Chinese philosopher that the work of MIHV and global health in general is to go to the people, live with them, learn from them, love them, start with what they know, build with what they have. But with the best leaders, when the work is done, the task accomplished, the people will say, we have done this ourselves. So lesson number 2 then is public health is about the public. That was actually a slogan that was being used about 20 years ago with the American Public Health Association. Let's put the public back into public health. And I might add, let's put the public back into health in general and healthcare. The intro there alluded to really the lack of democracy in health. So lesson number 2, public health is about the public, oddly enough. Well, the next guy that came along that gave me another window on public health was a MIH-free colleague on the board, Dr. Bert Hirschhorn, who was, as I say, he was a visiting professor actually over at the School of Public Health for a few years. The lesson here is to move the whole curve, not just the tail of the curve. And with this, now this is an old slide, you can probably tell, about 30 years old, from a very interesting book. But when I asked Bert what was the most important lesson in public health, he referred me to this book. And I think this chart graph actually tells a lot. It's a little bit complicated, so I'm going to leave it up there for a couple minutes. But if you look at the on the x-axis, there is cholesterol levels. Now, this is a study of about almost 400,000 American middle-aged men that was done over 6 years back in the 1980s. So you've got cholesterol levels on the x-axis there. Now the measures are a little different than what you're used to, because this is Rose is a Brit actually, so he uses the British measures. We measure cholesterol in milligrams per deciliter. So the numbers is everyone's probably had their cholesterol measured. They come out more like 200 plus or minus. The 200 on this graph would be a little over 5 there. On the y-axis, then on the left, you see the number of deaths that occurred per 1,000 men over that 6-year period. So you can see 2 or 3 different things here. One is that, like any distribution of most things, it's kind of a bell-shaped curve. It skews a little bit rightward, but it's pretty much bell-shaped. So the bars really represent how many of those men, that 360 some thousand, had cholesterol levels in that range. So if you go to the middle highest bar there and then go over to, let's see, which graph are we using? You know, they're both the same. So it's I guess about 20% or so of the men. Those percentages on the top are something else. I'll get to that in a minute. But anyway, it's a bell-shaped curve. Most of the people fall in the middle of the curve. The dotted line relates to the y-axis on the left and simply says that as your cholesterol level goes up, you have a greater risk of having a coronary heart disease death. And then finally, those percentages on the top of the bar represent of the total number of deaths over that 6-year period, what percent occurred in that cholesterol range. So what you see here is that most of the deaths occur in the middle of the curve because that's where most of the people are living in terms of cholesterol level. The mistake we sometimes make, and this is where medicine and public health kind of diverge, is we tend to think of those people way over on the end. So if you go to your doctor and your cholesterol level is 300, the physician's going to be jumping up and down and probably prescribing a medication. But if we only pay attention to those people that are way over on the end there, we're only getting 8% or maybe 8 plus 9% of the total deaths. So the point, as I mentioned earlier, is we want to try to move that whole curve, all of those bars to the left. And that requires things that are done more publicly, if you will, or across the whole population. So if we could, for instance, and this has happened actually over the last 20 or 30 years, we've lowered the amount of fat in foods, the amount of salt in foods. If you go to the grocery store now, it's quite easy to find low fat and low salt foods. And consequently, the incidence of coronary heart disease is down dramatically. Now, a lot of that relates to smoking too, but diet certainly is a part of it. And so the point here, as I say, is that you want to try to move all those bars over to the left, make the whole population healthier. Okay. Now, as my career went along, as Marty mentioned there, I ended up going to work for what is now called Health Partners. It was Group Health at the time. And then we basically acquired Regions Hospital back in about 1994. And I ended up working at Regions for several years, for a couple of years doing mostly hospital medicine. And I realized very quickly that I had practiced 12 years in Stillwater, but when I got over to Regions, where I had actually done a lot of my residency, but I had forgotten that the patients just seemed sicker. The diseases were all the same. You could look at the list of diseases and it was diabetes and heart disease and cancer and so forth, but it just seemed like people were, it was just harder to get people well and keep them well. And this was about the time in the mid to late 70s where we were hearing more and more about the so-called socioeconomic factors that affect health, or sometimes called health disparities back then. Now we talk more about health equity, really. So that was the kind of the fourth lesson is, and this graph here now will show this even better. If you think about the health of a community, it could be the whole state of Minnesota or the Twin Cities, whatever population you want to think about. There's really these four factors that come into play. Some debate about lifestyle and behavior and versus, now when I say environment, they're not just the physical environment, but the social, educational, income environment, all of that would go in there. Some debate about the line between environment and behavior. It should probably be a dotted line or a murky line of some sort, because clearly it depends on the environment as to how much you're really in control of your behavior. In other words, if there's not good walking paths or bike paths, it's harder to exercise. If you don't have access to healthy foods, it's harder to eat well. I just happened to run across a study out of England this morning showing that they're looking at it was 6,000 in some small population or geographic areas in England, and the difference in life expectancy, believe it or not, between the highest little area, small area, and the least is 14 years. So 14 years of life expectancy in England, depending on where you live, and it's similar in this country. In fact, you can go from maybe 10 miles and you'll see life expectancy differences of a good 10 years, say, between inner city areas and suburban areas. So location matters. And then I go on here to talk about having been on a committee that celebrated the 30th anniversary of Model Cities Health Center, now called Open Cities, actually, kind of in the heart of St. Paul, the old Rondo neighborhood. But Deb Olson was on the faculty in public health at the university, and I asked her for a good book. Neither one of us can remember the name of the book anymore. I just had lunch with Deb the other day, but it was just basically a book of stories. And what it pointed out is that in public health, you just have to try things. You make your best guess as to what might work. We've seen that in the last couple of years with the pandemic, obviously, and then do it and measure and see what's working and what isn't. I think the public has been a little bit confused and upset in the last 18 months because they're told to wear masks, and then they're told, well, masks don't matter, and then masks matter again. But that's the nature of public health, really. You just have to try things, see what's working and what isn't. And as I mentioned, take some risks and then adapt as you go along. I got interested more and more, as I've been saying, in public health, and joined the Minnesota Public Health Association in the year 2000 and served as president from 2008 to 2010. And one of the people I met early on was the former director of Dakota County Public Health, Donna Anderson, who very early on suggested to me what I really need to get involved in was the advocacy committee at MPHA, because it's really public advocacy that makes a difference in public health. There's actually, I think, of two big things in public health: public education and public policy and advocacy. Education clearly works sometimes for some people. And again, we've seen that with the pandemic, where some people just need to be told that it's time to get the vaccine and they do it. Others, it's more of a struggle, as we found out. This gives me an opportunity, and I know Ann Jones would get after me if I didn't take this opportunity to mention one of the advocacy things I'm involved with is Medicare for all at the state level here. Clearly, that would have to be coordinated with at the federal level, but some of us have been working on that for over 30 years now. And I think it's fair to say that a unified Medicare for all type system would not only be good for healthcare in terms of providing universal access and giving us some ways to control spending, but it would be much better for public health too, in many senses. But one for sure is the funding of public health is quite fragmented. I was surprised to learn that as I got more interested in public health, but and Antonia could talk to that better than I, and she probably will. But public health has become over many years kind of the poor stepchild of medicine. The funding is a grant here and a grant there. It's very, very fragmented, and I think in a unified system, and you see this if you look even going back to the Clinton era with their legislation that unfortunately didn't get very far, but with the current legislation now too in Congress, Bernie Sanders and others, there is a specific, I should say, funding set aside for public health so that it could be not only better funded, but better coordinated with the healthcare system and so forth. So anyway, a shout out for policy and advocacy there. I dropped this in mainly to point out that the notion of public health in Minnesota goes way back. Dr. Hewitt actually came to Red Wing shortly after the Civil War. He was a Civil War surgeon, and then came to Minnesota and set up practice, worked with the original Dr. Mayo and others down in that part of the state, and then went on to establish the Department of Health in Minnesota in 1872. A great quote from him there: "Prevention first, cure if you must, but have a capacity to go in both directions." So both public health and medicine. I know you've heard from Ed Ellinger before. I wanted to credit Ed with Ed makes great slides, so I tend to borrow from Ed. Now, this was a dramatic moment in 2006. Some of you might know that name, Lori Garrett. She was invited to be our commencement speaker that year at the School of Public Health at the university. And she no more got up to the podium than she looked out over the students, who of course always are sitting on the front. This was at Northrop Auditorium. And she said, there's something they didn't teach you in the School of Public Health. And of course, not only the students, but the faculty kind of sat up at that point. We were actually on the stage sitting behind her. And then she paused and said, courage. And of course, today we're in a Roman Catholic event and atmosphere here. That's of course one of your four cardinal virtues, often called fortitude. But we've seen this for sure in the last 18 months again, where public health workers have been threatened and this and that. If you talk to people in local public health agencies who've had to go to school boards and so forth and try to encourage the vaccine and mask wearing, they have had to have a lot of courage for sure. Now, over the last, going back to 1998, actually, most of that time, these two people, Ed Ellinger again and Jan Malcolm, have been our health commissioner. There was another interlude in there, but they've been the two key people at the health department. And they, to their credit, they have really pushed the idea of health equity. Ed talked a lot about health in all policies. So no matter what we're doing, whether it's housing or roads or whatever, that we think about the health impact. So that's another lesson that public health is really just about everything when you think about it. It's as I say, housing and food supply and clean air, clean water. It's many, many things. And there's been this discussion of health equities and health disparities and all that. But I think the way to think about it is, how do we maximize the potential health for all people? Really ought to be our goal. And then if you haven't heard this name, you have been, can I say, living under a rock, but Mike Osterholm, who I had the opportunity to be across the hall from over at the School of Public Health for 7 years, but he's been warning us, as you probably know, for a good 20 or 30 years now, that eventually one of these viral variants would come along and cause a lot of trouble. We thought it would be the flu, but here we are. It turned out to be coronavirus. I actually have a Mike Osterholm cup here. It says, "What would Osterholm do?" So the final lesson then really is that public health is global health. And again, I think the pandemic points that out, as well as anything, that if we don't take care of all of the world and try to keep everyone healthy, why diseases don't necessarily stay in one place. So I'm going to stop there then. I've been kind of watching the clock. I think we're about on track. So Marty, what's next?
Great. Well, thank you, Dr. Hart. And with that, we're going to move to our next presenter. And our next presenter is Antonia Wilcox. She completed her studies in critical pedagogy to guide her work at the Minnesota Department of Human Services as its Community Relations Director, serving as the bridge between cultural communities facing inequities in access and outcomes to services at the state's largest agency. She led efforts to bring institutions in meeting communities members where they were at, bringing her colleagues and leaders to engage in conversations, discussions, and dialogue to bring about equitable solutions. Dr. Wilcox brings decades of experience working in organizations, governmental agencies, and corporations, leading community engagement and meeting facilitation, planning and design, and vision processes to impact systems, change, equity, and social justice. As an independent consultant, she brings her commitment to racial equity and social justice to select audiences. Voices of community members influenced the strategic plan of the Cultural and Ethnic Communities Leadership Council, using the Institute of Cultural Affairs technology of participation methods. And with that, we welcome Antonia Wilcox as our next presenter. And Antonia, if you want, I can put your slides up and you can just tell me when to advance them.
Yes, please. Thank you, Marty, and thank you for that kind introduction. Good morning, everyone. It's a real tough task I have to go after Dr. Hart because his slides are quite impressive, and the quotes that he mentioned, Dr. Ehrlichman and others, are really something that I have been passionate about. I come to you from the perspective of an immigrant who was raised in poverty in a favela in the city of Vitória, Brazil. So that's where I grew up, and I completed college in a time in which for Black students, 100 students who entered primary school, about one graduated from college during those years. I never lived under a democracy. I grew up, and what I know in terms of my young adulthood was under a military dictatorship. So my perspective is informed by that. And then my 4 decades of living in this great state of Minnesota. So if I could please have the next slide, Marty. So because as an immigrant, I will always be an immigrant. I am a US citizen, but my heart is divided between Minnesota and the city I come from. I always want to make sure that I'm paying respect to those who lived here before us. And in that, we acknowledge that we're all living off the taken ancestral lands of indigenous people for thousands of years. We acknowledge the extraction of brilliance, energy, and life for labor forced upon people of African descent for more than 400 years. We celebrate the resilience and strength that all indigenous people and descendants of Africa have shown in this country and worldwide. We carry our ancestors in us, and we are continually called to be better as we lead this work. And this is from the American Medical Association Equity Strategic Plan. There are so many now of these acknowledgements, but these seem to be short but really pointed. Next slide, please. And I took a couple of quotes from writers that I admire and that I guide my work. And that's, of course, Grace Lee Boggs, who is a well-known human rights leader, has left quite a legacy as a child of Chinese immigrants in her book, Seeds of Change. And because we are living in such unconventional times, I thought it would be nice to stop and reflect that what she says. There are times to grow our souls. Each of us is called upon to embrace the conviction that despite the powers and principalities bent on commodifying all our human relationships, we have the power within us to create the world anew. And the world is coming at us, whether we are ready or not, it is changing. So we don't have much of a choice but to embrace it and adapt. And the next slide had another quote that I would like to share with you. And that's Tennessee. I'm always troubled by how to pronounce his first name. Quotes, the author and journalist in his book, Between the World and Me. But race is the child of racism, not the father. And the process of naming the people has never been a matter of genealogy and physiognomy, so much as one of hierarchy. Difference in hue and hair is old. And next slide. So I'm sorry, Dr. Hart, but there are some slides that are going to be similar to yours, because when I read the title that Jeanette gave to me, and I said, do we really have to consider that if public health matters? Of course it matters. As a poor girl growing up in Brazil, when we're taking the Sabin or Salk vaccines, we didn't know much what that was for, but it seemed to us that somebody wanted to protect our health and well-being. And I come from a country that used to be a leader in public health in terms of how we effectively vaccinated a whole population. And when I read that public health promotes and protects the health of people and the communities where they live, learn, work, and play. While a doctor treats people who are sick, those of us working in public health, and I count myself, even though I don't have a degree in public health, but I do have one by passion, we try to prevent people from getting sick or injured in the first place. We also promote wellness by encouraging healthy behaviors. Next slide, please. So there are 4 diseases that I found in this publication dated 2019 that have been eliminated in the United States in the last 100 years. Polio, measles, and rubella, as well as smallpox, have all been eliminated in the US. And smallpox has also been eradicated worldwide. So I'm going to say the politicized word now, vaccines, have been instrumental in the elimination of these illnesses. And as an aside, it's been interesting for me when I watch my community in Brazil on Facebook, in which people are taking the coronavirus vaccine and they have tears running down their cheeks saying, thank you for a unified healthcare system. It's poorly funded, it's terribly coordinated, but it is there. So people who have decided that they want to protect their health and that of their community are taking the vaccines. Next slide, please. And I would like to really talk a little bit about what I grew up under in Brazil. When I left Brazil, it was back in 1979. And there was a stellar immunization program in which Brazil was highlighted as having been able to vaccinate 10 million people for polio in a day. So right now, a lot of us are scratching our heads to try to understand what happened with COVID-19. Why is my country that values human lives, in which we don't have all the benefits and privileges that many other countries in the global north have, why do we find ourselves in this predicament? And a little bit about what this National Immunization Program, PNI would be the Portuguese initials, was created right in the middle of a military dictatorship. While dictatorship was not the best way to run our country, there were some qualities about it. The military government usually developed 5-year plans, and they hire people who graduated from the Chicago School of Economics or Sorbonne or the schools in London. And they were then the technocrats who came and tried to frame our country for a better future. So there was a successful completion of years-long smallpox vaccination campaign that eradicated the disease in the South American country. If you look at a map, Brazil has a great land mass. It's larger than the United States if you don't include Hawaii and Alaska. The population is about half or close to half of that in the United States, but it does have a great land mass and a very young population. And as you can see, 3 years after its initial creation, it was implemented under a federal decree. And the first step that was back then when we didn't talk yet about the universal access to healthcare. They created the infrastructure and the precursor to a public healthcare system known as SUS, which is, again, its Portuguese initials, created in 1988, post-military dictatorship. Next slide, please. And I was, as I was reading articles, and again, forgive me for pushing on Brazil, but because it's the country where I come from. It's where a lot of my values and a lot of my education orientation comes from. So this is really a recipe on how you dismantle a national immunization program. You add erratic planning, virus-denying president, and a vocal anti-vaccine movement. Sounds familiar? Yes, our current president is a great fan and close friend of your past president, of our past president. And they continue to be bosom buddies. As a matter of fact, as the Brazilian president tries to be reelected, he's contracting with the experts who elected our past president. So the death toll now in Brazil is second only to the US, first in the Americas with a number of 1,756 souls and deaths a day. And of course, because we are a country of young people, the younger Brazilians are being hardest hit. Next slide, please. When I go to the question, why does public health matters? Sometimes if I'm talking, and I learned in my work for the state of Minnesota that when we are talking with legislators and policymakers, it's much easier to present an argument in which they can see some concrete numbers, in which the experiences, the narratives are very important to have a broader understanding. But first, that legislator wants to know, how can I tell my constituency that this is an investment worth spending our time and our resources on? So back in 2015, 2016, I was working for the Department of Human Services. We had a community council that was created under legislation in 2013 to advise the Commission of Human Services on disparities in health outcomes, as well as access to the healthcare. And in those conversations, the subject came up in terms of how can we quantify disparities? What are some numbers that we could calculate so that we can give yet another side of that narrative that death is not something that we as humans, even though we know that's what's coming to all of us, we're not very comfortable talking about it. But when we put that in economic terms, so what are the economic benefits for lives saved? We know that Minnesota still has a very difficult challenge eliminating health disparities, health inequities. And we also know that there have been a number of efforts, research, and studies. We have yet to really move the needle. Blue Cross Blue Shield funded a study in which Dr. Sam Myers at the Roy Wilkins Center for Human Relations and Social Justice at the Humphrey School led. And we had several people, including the late Dr. Susie Nanny, who used to be serving on this council. And the findings of the economic benefits for lives saved was published that if the disparities in the state of Minnesota were eliminated, we could see at least an additional $1.2 billion in economic activity. The savings from work limiting health conditions that impact numbers of weeks, minorities or people in those populations missed during a day, a year, could bring over 247 million to the local economy. So again, this study addresses the economic costs of health-related disparities and does not address the well-documented structural barriers and other determinants of health. And Dr. Hart spoke about that, behaviors and environment and all that. Therefore, these cost estimates are conservative. Meanwhile, and this study was pre-COVID-19. We all know that that picture has changed significantly. But back then, Dr. Sam Myers wrote in the conclusion to that study that Minnesota's aging workforce has tightened the current job market near its full potential, meaning nearly one job for every applicant. Finding enough high-skilled workers will be among the top issues that face Minnesota's biggest companies in the coming years. And the coming years have come to haunt us. Next slide, please. I also went to the University of Minnesota Extension to see, so now this is COVID. We are living in the area of a pandemic. So in June 2020, Bridget Tuck, who is a senior economic impact analyst with University of Minnesota Extension, provided this analysis that Minnesotans filed 333,000 continuing unemployment claims. In the early months of 2020, Minnesota continuing claims hovered around 60,000. While the state's number of unemployment is certainly startling, a significant increase from the first months of 2020, continuing claims represent roughly 10% of all the jobs in the state. And we know that the professional services industries, because of hotels and restaurants and all those places where we like to congregate and socialize, were really the higher unemployment claim numbers. Next slide, please. So why does public health matter? I think it's not a question that I need to ask. It's something that I am convinced full-heartedly. But if someone needs convincing, I also read this article authored by Marion Nassau, who is with public health at New York University, and she wrote this for The Atlantic. Public health is a corporate group concern. So it's one of, and when she says corporate group, like a government, schools, companies, farms. It's the civil society. This is the grouping that we as a population look to. Public health includes things like properly working sewer systems, sanitation, water quality, and air quality. And some of these items I didn't grow up with. As a child, we didn't have running water. We had to bring water every weekend so that we had. Sanitation took a while to be installed in our neighborhood. Public health is a critically important expression of democracy and the antithesis of a corporate concern. So it approaches promoting good health for everyone, not just those who can afford it, but are educated enough to make appropriate choices. Public health makes it easier for individuals to make healthful food choices for themselves and their families. And public health makes better food choices the default. And because public health applies to everyone, it is essentially democratic. And that's one of the reasons that Marion says why I think it matters so much. And I couldn't agree with her more. I am a child of military dictatorship living now in a democracy. And I'm telling you, I know the difference. Next slide, please. I would like to thank you. I may have gone pretty quickly with my slides. I appreciate your attention. Thank you so much for the invitation to be here, spend time with you. and especially presenting aside with Dr. Jim Hart. What an honor. Thank you. And I will stay on if there are questions or discussions that we can talk some more.
Thank you, Antonia. And we're going to come back with questions in a little bit, but we have a group of students from a public health class here at St. Kate's who are going to give some very short presentations from their learnings of why public health matters. So I'm going to turn it over to Professor Green, and she's going to introduce the class assignment and her students.
To introduce students from the St. Kate's Foundations of Public Health course. These students have been learning all semester, like you have, why public health matters, what it is, first of all, and what can be done to improve health equity. So they're going to share some very brief talks on some topics that you may or may not associate with public health, and tell you about why it matters, why it's a health equity issue, either what has been done about it or what could be done about it, and then what could the impact be. So with that, I'll welcome our first group who's going to talk about oral care.
Oh, this is okay. I thought this was the last one. So the impact on oral health in children, if it's not treated properly, can lead to infections and problems with learning, speaking, and playing. It could also lead to worse chronic conditions growing up. This heavily impacts children in low-income families and children with children of color. And according to the 2017 Minnesota Department of Health, 66% of the Hispanic third graders had current or past tooth decay.
So what can be done to address this inequity? One way that we can address oral health inequities is through school-based sealant programs. And this helps because it brings care to people directly. A sealant is a protective coating placed over the back teeth to help prevent cavities and has been found to be very, very effective. Part of the reason why this can help address the barriers and inequities is because it allows students, no matter their socioeconomic background or race and ethnicity, to receive care. And in a study, it was found that for every 1,000 sealants given, it prevents 485 potential cavities.
Promoting good oral health care habits at a young age is important as it will lower the need for urgent oral and lower the need for serious oral health conditions. Another way of increasing health equity is the school sealant programs, as Angie said. Mentioning before, every kid, no matter race, ethnicity, religious beliefs, income levels, or even their zip code, should have access to their resources provided and have increased oral care equity. It is commonly forgotten that good oral care affects a person's general health. With that being said, children with good oral hygiene will have better oral health. As we take action to create better oral health care system, it will increase our health equity. Thank you.
So our public health issue is clean water, and clean water is important for everyone. Everyone should have the right to have clean drinking water. Clean water is essential to living a healthy and long life. And when water is contaminated, it can spread diseases such as cholera and typhoid. And diarrhea is one of the main causes of death for children under 5, which can be easily prevented by having clean drinking water. Thanks to public health, we have found ways to prevent these health risks and to intervene when needed. One of the main ways that public health has worked to intervene in this public health issue of clean drinking water is filtration, and that's just the pathogen removal through water filters. And one example of this is in Oakdale, Minnesota in 2006, when we implemented a filtration system and it successfully reduced the amount of exposure to chemicals in drinking water. And lastly, the Safe Drinking Water Act and the Clean Water Act are 2 ways that we intervened in. Asmita will talk more about those.
Impact on clean water, ensuring clean water and sanitation. A study has shown that 2 billion people lack access to safely managed drinking water services, and each day nearly 1,000 children die due to preventable water. So sanitation and good hygiene practices are must, and have helped improve on clean drinking water, realizing that access to safe water and sanitation are human rights. Safe Drinking Water Act was introduced in US from 1974 to 2004 to protect public health by regulating the nation's public drinking water supply. Because of disposing chemicals, pesticides, waste injected, and naturally causes substances can contaminate all drinking water, and if not treated properly or disinfected, it may or can pose a health risk. Thank you.
Hi, my name's Allie. I'm Gao.
I'm Han.
And I'm Tomi. All right, so our issue is about sexual health concerns. And this is a concern for the public health because STD rates are rapidly increasing in Minnesota. For example, from 2008 to 2018, chlamydia has increased by 68%, gonorrhea by 145%, and syphilis by 246%. While teen pregnancy is declining overall, the lack of prevention methods are evident in low-income populations, and the current sexual health initiatives do not meet the needs of the current time. And this is relate to health equity because social determinants such as socioeconomic level, education level, healthcare access, they all influence sexual health outcomes in BIPOC communities, LGBTQ populations, and homeless incarcerated teens and those in foster care.
Okay, and so some interventions that are needed are revamping some old model, introducing comprehensive sexual health education, which is educating youth about like condom, contraception, which provides various of protections, which will decrease the risk of sexual behavior. And the Minnesota Health Department have made some programs such as the personal responsibility education, which addresses the disparities in teen pregnancies, STD, and HIVs among the disenfranchised communities. And the strategy is to focus on empowering the youth to make their own healthy decisions, so to lower the decrease of teen pregnancy, STD, HIVs.
So what would this impact in public health? It will provide an age-appropriate sexual health education curriculum that will reduce sexual health risk behaviors. It will also influence decision-making strategies that will include resources like the Minnesota PrEP program, Be Proud, Be Responsible, and prompting a decrease in teenage pregnancies and STDs within the communities of color. Thank you.
There you go. Okay. So today we'll be talking about how prison is a health disparity. In Minnesota, there are 7,639 people incarcerated. Minnesota alone has 11 state prisons, with 10 of those being for men and 1 housing all levels of women. As we look into how Minnesota prison systems affect those incarcerated and the community around us, with data, health determinants, and interventions, we will show the links between the cause and effects of the prison system.
Some interventions that have been taking place in order to fix this problem are the following. The Minnesota Department of Corrections partnered with the Recovery Corps to design a program where those with direct and indirect experiences in recovery serve other individuals that are trying to sustain their own recovery. Also, chemical dependency treatments and interventions related to these 2 following factors: the increase of chemical dependency treatment beds funded by legislature and the decrease in the length of the treatment that the offenders need to complete. It used to be 200 days, and now it just decreased to 180 days. The HIV/AIDS Health Improvement for Reentry Program grant is a program where recently incarcerated individuals can find support to help their HIV and AIDS health improve. There's also a relink intervention where 18 to 26-year-olds recently released from jail can address their health challenges in hopes of finding a new effective way to obtain health care, housing, education, and employment. And finally, there's a minority youth violence prevention, and it is an incentive to reduce disparities across public health that in those individuals that have been incarcerated.
So only 5% of There we go. Okay, so only 5% of Minnesota population is Black or African American, yet this makes up 37% of the prison demographic. And this leaves a lot of communities without leadership and with the feeling of being discriminated against without the voice to stand up. So with these interventions and impacts, there are ways to make change within our community to fix this disparity in the prison system, as well as the rates of incarceration as a whole. So these interventions include resources for mental health, counseling for addiction, and services for difficulties that may come from the release, which has then made it less likely to re-enter the prison system, succeed in the community, and be able to have a success story. As of right now, 75% of offenders do not return to prison, and by keeping up with these resources and interventions, that number will just keep increasing over time.
Hi, everyone. So our issue is food disparities. Everyone around the world suffers food insecurity. In Minnesota, 1 in 13 does not have regular access to food. Okay, so there's a few different interventions. There's federal programs like SNAP, which is available to low-income households. There's WIC, which guarantees healthy foods to families with children, small children. And then there's the Head Start program also that encourages family-style dining. There's also many local programs available, including
different food shelves, Meals on Wheels, and even the food shelf here at St. Kate's.
So the impact on this is that 38% of homes in Minnesota receive SNAPs has children. SNAP creates $866 million in revenue and economic activities. So these programs not only help feed families, but they stimulate the economy. Thank you.
Many immunizations are required for children in order to go to school. Specific immunizations may vary depending on the location of the school due to state laws. Children who are uninsured have a greater risk of not receiving the immunizations that are required. Insurance coincides with access to healthcare systems and is a major determinant of health, as children who are uninsured have lower rates of immunization. In order to better the health disparity of immunizations in children, the determinants need to be identified so interventions can be set in place.
One important intervention that we talked about was the Vaccines for Children program, which has been implemented in various states throughout the US. It is a federally funded program that is intended to provide vaccinations at low or no cost to children who would otherwise not be able to access those vaccines, such as under or uninsured children.
These disparities for children mainly impact those belonging to minority groups such as Latino, African American, Native American, and Asian children. And as a result of the Vaccines for Children intervention, there's been a 158.8% increase in vaccination administration for specific vaccines such as HPV, Tdap, meningococcal, and seasonal influenza. In terms of public health, this program aims to reduce levels of vaccine preventable diseases in minority children and improve their overall health outcomes and health status. And preventing these diseases helps prolong their lives and promote better physical health.
And our climate change group couldn't make it this morning, so I didn't do the research for them, but I can tell you that they've talked a lot about how climate change is affecting all aspects of our lives and isn't always talked about in terms of a health issue, but it affects the food system, it affects people, the economy, and specifically is going to impact others. And they found an approach that has been implemented in parts of Africa where they're looking at different ways to measure what the potential impact of climate change could be so that governments and community organizations can step in and really target their interventions towards which part of people's lives are going to be most affected and how can we step in to intervene and prevent things like food insecurity from becoming worse than it already is. And so they're recommending that this be implemented here in the US as well, so that we can see what households are lacking and what areas of their lives need to be stabilized. And so, thank you. And I want to give a round of applause so you all on Zoom can make some silent applause if you want to for all of our students and all the hard work that they've put into these presentations. And they also wrote some fabulous papers about these topics as well. So we hope that you be and can think about in terms of your own behavior and advocacy and education, where can we step in Minnesota to help decrease these health disparities?
Again, just a round of applause and thanks to all our presenters, especially our students. We know they were a little nervous, but they did a fabulous job helping us to see public health, why it matters. We have about 15 minutes remaining that we do this as a Zoom meeting, so it's an open conversation, including students here in the chapel, to ask questions. So please just unmute yourself and ask a question of the panelist, Antonia, Dr. Hart, or our students. So I open it to anyone who has a comment, question, thought. And maybe I could prompt the students if they pass the mic around, but how is this paralleling what you're learning in your public health class? Or is there anything new that our two speakers presented today?
Hi, my name is Steve Janis, and I'm not a student. I'm an older person here, very much involved with trying to help the financial aspects of how we pay for our health care and all. But I'm also the husband of a retired public health nurse, and so I really have come to appreciate public health. And I think the topic today has really been helpful for me again to remember that we need to help fund and give support to people who are in the public health arena. Thank you.
I too was thinking about that area, and Dr. Wilcoxon, what you were talking about in relation to the economic benefits. Do you believe that if we focused on that a little more, what would be the major area that we really could focus on that might make a difference?
Very complex question, a very difficult question, and I would not pretend to know, but I'll offer my ideas. I think that I presented the economic benefits because that was something that was really compelling for our group of community members as well as state employees at the time. And the fact that we know the economic factor is a very powerful factor when we operate in a democracy such as ours. There is also, of course, the moral issue and also our own commitment to democracy. We want our communities to be healthy. We want our communities to be thriving because that does not only benefit you and me, but it benefits everyone. That when we have equity and people are able to access the conditions to be healthy, they are productive, they can contribute to the local economy, as well as they have families who are thriving. Students are doing better in school because their parents have access to livable wages, for example, or they have access to housing that is not in a dangerous or violent community. So, and public health really overlooks all of this because we can't separate the well-being of a human being from all the other factors that protect that. While we're grateful to medical doctors because we can go to them to help alleviate our pain, public health takes care of the whole community. We're drinking filtered water. Our children are being vaccinated so they don't fall ill for diseases that are avoidable these days. Very complex. I think that I chose to show a little bit of the economic side of it because we don't usually talk much about it. But if we come to understand that in the United States, large democracy, we pay one of the highest healthcare system in terms of cost. And we don't necessarily benefit from quality if we look around in an equitable manner, that some people have better access to better healthcare than others. And it's dependent, of course, on a lot of factors. This is an incomplete answer, but this is my best. Thank you for your question.
Marty, might I comment?
Go ahead, Ann.
Thank you so much to our speakers and our and presenters. Absolutely correct, Antonia. And I would be remiss if I did not invite everyone on this at this conference to consider helping us advocate for change. We're spending a lot of money. We're not getting our money's worth, and it's a justice issue as well. So I put our contact information in our website, healthcareforallminnesota.org, in the chat. If you would like to get involved with an organization that is working to fix how we pay for healthcare, and then, of course, more broadly affect how we do a better job of coordinating public health services in this country, ultimately. hca-mn.org, put your contact information in. You'll hear about events like this and ways to engage and help fix this.
Thank you.
Thanks, Ann. And I know our students can't see the chat in the chapel here on our big screen, but I'll just read a few of the items in the chat in addition to what Ann just shared. We have thanks to all the presentations. Public health can be a unifying factor in society, as pointed out today. Another comment, thanks to all the thanks to all the presentations. Whoops, for some reason that one's not. There we go. Thank you to all our speakers and especially our students. Job well done. The future is in your hands.
Jim Hart here, and I like that comment about a unifying factor. We're so fragmented now, as we know, polarized, I guess, is the word that's commonly used. And I think even now you watch what's happening in Washington, and the idea is, well, we've all got to come together before we can get anything done. But the flip side of that would be maybe we should do something and then get unified. In other words, if we had a universal common health system, that would give us all something to kind of buy into and work together on. So that's maybe another way of looking at things.
And by the way, those of us who advocate for a unified system are talking about absolutely everyone who lives in this country and in our state of Minnesota, not related to, removing any eligibility barriers. We are talking about everybody and all means all.
I really liked the student presentations because they were so diverse. It points out that in the end, almost everything contributes to health in one way or another. So very well done. Some great examples.
I agree. Congratulations to the students for your study and research. Very well presented.
Well, I'd be curious, Dr. Hart, as you talked about your lessons, one of them was courage. So wondering, as the students were doing some of their research on their topics, where do you think courage is needed in public health going forward?
I think courage is needed just to be able, just to be able to speak out and use our voices. We do have a powerful voice. And just from researching and learning so much, we know what we're talking about. So if we actually use our voice to our advantage, I think that'd be really helpful. And we have this community at St. Kate's around us that would back us up and be able to give us what we need that we may not have just on our own. So I think just with the community of students and then the help of St. Kate's, using that courage and our voice to speak out will really help advance some of these topics that we're talking about as a health disparity.
I think there's also, with a lot of the things that we talked about, there's a lot of stigmas, either like not wanting people to know your socioeconomic status or your like medical history and stuff. So maybe courage can be used there in order to help regulate those and like normalize that these things happen and they need to be addressed.
Also, I think courage to stand up and voice things that you might find concerning. Like some of the topics we went over, I don't think a lot of us like connect to public health, but it is. And like we all have very strong opinions on that. So using our courage and our strength to speak up and be like, this is what I noticed, and this is a disparity here. Let's figure out how we can like work together to make it more, well, not equal, but like make sure that equity is working through everything.
Our generation, I think, has a really big influence on like changing the society and the world. So I think if we all come together and stand up for what we believe is right, that we can do so many great things, and that more than other generations, that we are really influential to the society.
The question from Professor Green was, where do I see courage? And maybe I could put that out to Dr. Hart and Wilcoxon as well. Where do you see we need courage going forward? And I guess I look at it in the sense of we're in the, I think, still very much in the middle of a pandemic. And I think if we think back 50 years from now, they're going to look back on what did we do or where did we have courage in this pandemic. I think it's just so critical. So just wondering, Antonia or Jim, where do you see courage today in public health? And where could we maybe use a little more courage?
Well, I can jump in. I kind of alluded to this in my remarks. It's a sad tale, actually. There was an article in I think the New York Times this week about I think it's 5,000 public health workers that have actually quit over the last couple of years. They're being threatened with everything up to and including death, actually. So it's very difficult to think about that. These are people that are simply out there kind of telling the truth. So I guess a quick summary would be we just simply need people that are willing to stick their neck out and do the right thing and tell the truth, and maybe not worry so much about trying to convince people that can't be convinced, but just keep plowing ahead, doing the right thing, and relying on the best science and the best truth and the best for the common good, and just keep moving forward.
This is a very important question. And if we go back to the year 2020, when Mr. George Floyd was murdered, and young people went on the streets, and you may call it whatever, I call it insurrection, and I call it a very courageous act. They were in masks. They knew we were in the middle of a pandemic that could have killed them, but they were out there protesting and lending their voices and not allowing themselves to go silent, even when they were being attacked by others who did not understand why they were protesting. And it is really painful to watch. This is my country too, where we find ourselves right now, in which health professionals are doubting the science in which they were trained and that they committed to serve, as well as when our professionals are so exhausted that they are at a point that say, I can't do this anymore. And where is the courage then coming from influential those who have the privilege, and those who can look beyond the appearances, beyond skin color, beyond age, beyond a whole lot of obstacles that we put in front of ourselves, to just claim that social justice and that what this country stands for is not that complicated. It's about seeing each one of us as human beings. It's about caring for one another, because we are all we have left. Nobody's going to come and save us, but we as a community, we as a population, and especially living in a democracy in which we can vote. We don't need to be afraid of, though I know that there have been violent acts. But when we look at past history, all these movements that produce what we now benefit took risks, and taking risks is part of this work. So I think it's distressing sometimes how reluctantly decisions are being made in Washington, D.C., or in St. Paul at the state capitol. Where is the public will? Where is the public courage? We need to do better.
Well, and maybe connected to that is a question from Rose in the chat, and I'm going to just jump to her last question in the chat. How do we prioritize public health without a public health care system?
Yeah.
Yeah, there's a common theme here. Thanks for that, Rose. I mean, you can do it, but we see what happens. We've got over 700,000 deaths and one of the highest disease rates in the world, even though we will spend about $4 trillion this year on healthcare in this country. So I guess all I can say is yes, that's what we need, a better coordinated system. Like one of the questions was, let me just take a look at it here now, was what is the importance of public health as it relates to the medical system or the healthcare system? And I think Antonia hit on it there. If we don't do public health well, we end up overwhelming our healthcare system. And you're all reading and seeing the same things I am now. We've just really completely exhausted our healthcare system. So back to where we started, Marty, in a way, I guess, is we've got to put the public back into this. Public health is everybody's responsibility, really, to make good decisions, use your own good judgment, but respect science and so forth, and maybe give a public health nurse or a community health worker a hug when you get a chance.
So true. Thank you, Dr. Hart.
Yeah, I think our public health and all our healthcare workers have been under a lot of stress the last 18, 19 months.
Yes.
I know we're pushing up on time here. Dr. Ellen is the co-chair of our Healthcare for All working group here with the Sisters of St. Joseph and Consociates. And I wanted to give her a chance just to maybe say some words of thanks to our presenters and for everyone attending today, and a little plug to consider joining the CSJ Healthcare for All working group if you're interested in getting involved in hosting these events and doing systemic change and advocacy actions. But Dr. Ellen, if you want to unmute yourself and give a word of thanks from the committee.
Okay. All right. Well, yes, thank you very much to both of our main speakers and to the students. It's very eye-opening. It's information that needs to get out there and certainly get out to the public. If anyone is interested in coming to our Healthcare for All meetings, we meet the second Tuesday of the month, and it's 3:30 in the afternoon, and we've been meeting on Zoom, of course, but we would welcome any of you that would like to come and participate. If you have questions, Marty, I think your email is on the website, the Sisters Justice Commission website, for contact, correct?
Yes, it's on the website, and we are also will be sending out evaluation at the end of this. So if you logged in through the Zoom link, we'll send you a short evaluation of what did you take away from today's talk. But with that, again, just a big thanks to our two presenters, Jim and Antonia, but all our student presenters as well. I know it was a big day for them, and we're just very, very grateful to all of you for helping us to think about public health and why it matters. Thank you, everyone,
Thanks for the
and
invitation.
blessings on your day.
Thank you.
Marty, are we done?
We are done, Dr. Hart. Thank you
Okay.
so much. It was a really wonderful, thought-provoking morning, so I appreciate it.
Yeah, my pleasure. Yeah, there was something about a 15-minute Q&A at 10:30 there, but
Well, and I think we
got it in
ended
early.
a little early, and so we had time for that at the end of the program at the
okay.
end. So I think we worked out well.
Quick question. I had a patient named Ruth Roars in Stillwater. Any connection?
Yep. Any roars? We're a small clan, so yes, we're related. I would probably be my dad's third cousin, I think.
Okay, yeah, you may know she was a nun.
Yes.
Yes,
Just
Sister
with
Ruth, yeah.
with this community here that I'm working with. Yep.
Yeah, dear lady. Well, very good. Yeah, thanks for your help. That went very well. And I'm actually on the advisory committee